This feels like a Friday still. I always thought, maybe. Yeah, you're right. It's been a tough, it's been a tough night. I always have that problem with this shit for some reason because it looks the same. This looks the same.
Because I saw that and then I saw the tag.
I know. Yeah, the tag. It's a look.
It's a look.
It used to be a look, actually.
Trendsetters.
Thanks for noticing.
Looks like everyone's going to be filming you.
It's got the pressure.
Yeah, show the knees on here in shorts, and I'll be like, I don't think those shorts have it. Do what? You know what?
This is fine.
Which, by the way, I'm transitioning soon from the vaccine.
Which hospital are you from? Which hospital?
I was in Miami.
Oh, yeah.
The one that they had in
He's
UM.
my right side.
Oh, Miller?
Right next to the
Oh, that's good.
optometrist.
Just wait for the
Big university hospital.
You might as well wait for
and
the
then
8.
you can just like.
I always drive my mom there because she has eye problems, so she goes to the.
Oh, really?
I forgot that guy's name.
It's
very fun.
Yeah.
I'm probably gonna get it. I'm gonna get it too by the end. Retro recording? Oh, y'all record. Oh, you can. Would most of you, if I have AV group come over here, the tech group, and record the objective, the stations, would that be helpful?
Yes.
Yeah.
Yes.
I don't know if that's gonna help for you guys, but I might start that for next year.
Yeah.
So I thought it'd be nice to also show like the area and label the different things, so you guys will have all that.
Really helpful.
Yeah.
Yeah, every year. So 5 years from now, if we're doing that, everybody's like, oh yeah, we do that, you'd be like, yeah, lucky you. The last group who didn't get that. But, so what I try to do to start when I'm practicing for the checkoff is try to create the station. Okay.
Yeah,
He breathes.
yeah.
I didn't know that.
That's crazy.
So set the station up, and if you need to ask me, as close to as much information as I'll give you about the final, because I'm probably not going to have all this junk sitting on the table, right? I just have it there so you guys can practice, and that's just confusing when it's all there. This is what you're going to see on the table in front of you. And at every station, including this one, I'm going to focus on, think through what my steps are first. So what is it that I have to do at the station? It's going to be on my sheet of paper, and it's going to be to insert a trach. What supplies do I need to insert a trach? I obviously need a trach. I need my obturator. I need an inner cannula, in this case this one's in here, and a 10 cc syringe. So I want to make sure that's all available at the station. I also need lubricant, but remember for lab purposes we don't gunk the mannequin up, so we don't use that. After I insert it, what am I going to need? I want to do something to confirm placement, so I should probably have an amber bag here. This is a bad example because I don't have one over here, but I'll bring one over in a few minutes. Oh, sure. Yeah, let's do it the real way. And then the next steps are to do what? Let's see. We're going to try the patient on a passing mirror valve. So in order to do that, I need to remember to deflate. Always, always, always deflate my cuff. I'm going to tell myself that every time I think about it so I don't forget. So I need my passing mirror valve. Which is right here.
Right, purple.
So I have that ready to go. And then after that, we're probably going to either do a capping trial or clean or something to that effect.
Between the aqua and
One's the vent.
The aqua is for the ventilator. This is for spontaneous patients. There is another color, I think it's clear one or something, I can't remember. Did anybody go by that booth at the conference?
Which one?
Passing
Oh,
mirror.
yeah, I get
They
you.
had a booth there with all of them. So then I have my stuff for cleaning. And then if we're going to decannulate and everything, let's keep this here. All right, makes sense so far? Okay. Then I want to get my patient positioned. He is going to start on oxygen like this, so you won't have to probably set up the mask and everything. But if he's not on anything, you don't really have to worry about it. But if he's on this, what do you want to remember during this test?
As quick as possible.
Yeah, every step, make sure you're reoxygenating him as much as you can. We would probably have him on a pulse oximeter if this was in real life. But I have a sneaking suspicion his fingers have poor perfusion, so we're not going to remember often. But if you would just say, I might ask you, what would you be monitoring right now? And if you say his appearance, you'll always be right if you say appearance. But I also want you to say pulse oximetry. So I'm just going to keep this at the bedside if I need it. Now remember, this one's this is that one that you're not going to find in a clinic because I actually can't hook this up if I need an emergency. What would I need?
A tree.
So I would want to make sure of that. Take a second. Wash my hands, put gloves on. Now, remember this isn't a package, so I'm going to check my cuff just like I do with the endotracheal tube. And through the package, I'm going to palpate the cuff. I think the other one's actually blown. Didn't some of us learned that the other day? Is that your group? Yeah. I'm going to then completely deflate the cuff. In this case, we have an inner cannula in there, so I'm going to take that out and put my obturator in. In this part, I don't care about, but I put my syringe back on just so it's ready to go. All right, Mr. Smith, my name is Scott. I'm a respiratory therapist. I'm going to put a tube in your neck today. We're going to take these pillows out just for a few minutes. So I want to get him into sniffing position, right? Mm-hmm. Get our tie right over here so it's close by.
You just move this closer.
And I have my drainage sponge. All right, Fred, we're going to take this oxygen off for a minute. And remember when inserting, I'm going to insert from the side and then kind of roll down or turn down. And this is not unheard of in the real world either. There we go. I'm immediately taking the obturator out.
Put the inner cannula.
Inner cannula in. Inflate my cuff. I would check my cuff pressure later, so right now I'm not as concerned with exactly how much is in there, but I would check all around. And then you can kind of go either way with this, but it's easier to put your drainage in now.
But normally, would we bag and check to see for chest rise?
And tidal CO2 you could do. You're
Okay.
still checking for chest rise. I can hear him breathing. He's doing pretty good right now. But
So we could just say that, I guess.
and then I'm just going to put this on. How tight should this be?
2 fingers.
Yeah. And for whoever's been practicing, anytime I walk over, you'll notice I check that a lot. That's one of the things that I pay attention to. And again, as long as it's close, I'm happy. I don't. Two of our graduates just got hired into LTACs, long-term acute care facilities, and there's tons. One of them has 66 trachs right now. So you're doing this over and over and over, and they're all on vent. Most of them are on vents.
We're at Kindred, or? Is
No,
it?
they're working with the kids.
Okay, it's up here.
All right, so I'm gonna just check. I think that one's pretty good. So now I want to get him. All right, we're gonna get your head back up, Fred. In 20, but
Okay.
all right, so he's pretty good to go, right? So that's it for the first stage. So really the parts that you want to pay attention to are making sure you check your cuff first, and then getting him into the correct position, and keeping him oxygenated. Those are kind of my keys as I do it. Oh, and don't let go of the trach. That's probably the number one mistake at the station, is letting go of the trach. Now, if you do it like this and you go right back, that's probably okay, because in the real world, if you do that, you know, they're not going to probably cough you out that fast. But if you stop and you do something, you know, then it's probably too late. Okay, any questions up to there?
Nope.
Okay. Next up is passing-mirror valve. So to do a passing-mirror valve, I want you to be able to tell me why you would do it. We're using it as a tool to enable him to talk. I talked about this as pretty common during the weaning process, but don't confuse it as a weaning step, because we do this on the ventilator with patients who don't wean. One of the ladies, I did it with pulmonary artery hypertension. She was probably never coming off the ventilator, so we were able to put this in line so she could communicate with family and caregivers. So this is actually pretty easy. This is the only critical step, right? And I'm just going to make sure I've pulled all the air out. I can see it's pretty flat, but. All right, Fred, we're going to put this little valve on and see if you can say a few words to us. All right, can you talk? I think you might be able to.
He talks and breathes.
Oh, he's not cooperating.
Today?
Come on, say something.
Something.
Thank you.
Ah.
Can you make him talk again?
Well, that's what you're trying to do, right?
Yes. You don't like that? I guess he doesn't like the passing-mirror valve. But remember,
Good for you.
now he's vocalizing through his upper airway. And by the way, I will not make him scream or do anything. Even though towards the end of testing, I look for ways to entertain myself. But it's not going to be at your expense.
So how does sim ones work as well?
The sim ones are a lot more complicated than that. We actually have microphones,
Yeah, you
and we're
could talk.
talking through them. It works good most of the time. Every once in a while, you'll have a female patient, and you'll hear a male voice. You know, those things happen. So that's it. We're going to stay with him for how long?
Good day.
For how long?
10, 15 minutes.
I'm going to stay at his bedside for at least 10, 15, 20 minutes. Somewhere in there.
Make sure it's not
For the first time that he wears this. And the other thing I want to make sure I do is I communicate with everybody around me that he has a passing-mirror valve on, so they need to make sure that they keep the cuff deflated. Yeah. That's it for that. So that one's a really easy step. Let's cap while we're here. I wish he said more things. He'll just keep moaning.
That means he wants a cap.
You want the cap, right? So the nice thing if we go right from passing-mirror to cap is there's the only thing that you might want to do, just train yourself this way, feel it again. You know, just get in that habit that you're paranoid about the cuff being up. That will help you not do anything in the real world. All right, right, so we're gonna twist. Oh, one thing I told a few people, but I guess I didn't get to everybody. When you put the Passy-Mare valve on, and the same as when you're using this, if you twist it, it stays on better. So I think one group was having trouble because they would just push this in and it would pop out like that. If you twist it a little bit,
Oh,
it won't come out.
okay.
And it's the same with this. This kind of twists on, and the friction will hold it on a little bit better. Take that off. Okay, so to put this on, if I make a mistake and I forget because I'm nervous during the exam, and I go like this, that's okay. But I need to recognize something's not working, right? So as long as you can self-correct and figure it out, I'm just gonna stand back and let you do that. Because if I was testing even today, I might do the same thing. You know, you just kind of get nervous and stuff. All right, so we're gonna take your inner cannula out. And let's put this little cap on there. Remember they're alligator clips, so keep checking to make sure.
You're gonna check that.
What do I need to do as well at this time?
Put the oxygen on top.
Yeah, so now you need to recognize that the oxygen needs to flip from, because is the oxygen able to get in there? No. So he would be hypoxemic now. So I need to flip over, and I'm not gonna do this. I didn't bring a nasal cannula over, but I would put a nasal cannula probably on him. If you're wondering why nasal cannula, most of the time at this point they're not on a lot of oxygen if we're capping them. So I might just put them on a couple liters. If you said venti, it's fine too. It's not gonna.
For the checkoff, do you want us to put them on a nasal cannula?
Yeah, I think possibly this is where I have you test out. This is how I test you on the nasal cannulas at the station.
Oh, okay.
I just can't remember my combination, but it seems like a very logical one because you get a couple of skills all at once. So then you would just say, "Are you doing okay, Fred?" That sounds like a yes, right? So let's get this off so it doesn't look weird. But he's actually 100% for today. His SpO2 is 100%, so we're going to just leave him off now. We're going to leave this in for about 24 hours. Okay, so let's take a step backwards. I'm going to take this back out. And the only other skill that's testable here is trach care. Out of all of these that we've talked about so far, you won't do these other ones that much during the beginning of your clinicals, but this part, cleaning, you'll do quite a bit. You know, every time you have a trach patient, you'll be responsible with help to do that. So I want to get my kit ready, right? Remember there's a difference between an inner cannula that's disposable and an inner cannula that's non-disposable. For lab purposes, we're going to use the disposable ones. And I would say 99% of the time at the hospital, that's what you'll see as well. So I'm going to open this. I don't really need the gloves. We have the drape in here. I'm going to put this on him just to catch anything.
Is the rough side out or the smooth?
Yeah, if you think about, kind of keep in your mind, if you've ever felt a diaper, keep that thought in your mind.
Okay.
If you had the shiny part towards the baby, it's going to create a mess, right? It's going to roll all down the way. It will be gross. The absorbent side is up. I didn't bring it up again.
He's just, he's got friends.
This is just, what was this called? Does anybody remember?
Tie?
The twill tape.
Oh, twill tape.
I
Oh,
don't know.
twill.
We don't generally use it except for trauma patient stuff. Occasionally some patients come out from the OR.
And where does that get placed?
This is instead of the commercial tie. All right, and then I'm gonna have some water or something, right? So we're gonna pour some sterile water in there. When would we use hydrogen peroxide?
Doing the
Yeah,
non.
if it's really kind of gunky looking. Then we would mix that 50-50 or 1-to-1 with some water. Lots of times people will pour the water right on the 4x4s. That's okay too. I don't care. To save a little bit in the lab this year, I've not had us wetting those. If you really want to just get the feel for it, you're welcome to. I just didn't want to, every time you wet them, you have to throw everything away. And then I need my new inner cannula. So I'll have this at the station.
Right.
It'll be in the package.
That comes in the
No, this is separate. So when you're working clinically, you'll grab one of these from the equipment area and you'll match up the numbers. So see that one says 8 DIC on it. DIC stands for disposable inner cannula.
The other part, were we supposed to also have a backup trach? I remember at the end of the list, there was a backup trach needed
At the station.
at the
yeah.
station.
And we have it.
Okay.
We just moved it out of the way,
Okay.
so we don't need it right now.
For testing, it's gonna be on the thing.
On the stainless steel,
Yeah. I mean, just the extra.
probably. In the hospital, we would either use their bedside table or sometimes the counter. Sometimes we'll put it like on the side of the bed if we really have to, but you know, if you do that, if you move their leg, it goes all over the floor. So. All right, so now I'm gonna get ready to clean. I'm gonna make sure this is within. So as soon as I've made the decision to take the tie off, same rule applies, right? Don't let go. The cleaning steps, I mean, you can kind of do those in whatever order you're comfortable with. So I'm more watching to see whether you're going to let go or not, whether you're monitoring. And if he's on oxygen, we want to keep our oxygen at least close by. It's not possible really to clean and have your oxygen right here. Remember, if he's on a ventilator, you would have a tube attached here all the time and you just kind of work around it. So. All right, so I have that off. Now I'm going to clean. I'm going to take my first 4x4. I'm going to kind of clean around here. You'll see sometimes it looks just like this and it's beautiful, and other times it has like dry airway boogers on it. So you have to scrub those a little bit. That's the only time I might use this. Remember, we're never going to insert this into the airway. This is actually meant for a non-disposable inner cannula. But if it's really gunky, as long as I don't touch his skin, I might use that.
Does it hurt if you touch their skin?
Yeah, I mean, did you feel it?
No.
Like a bottle scrubber.
Yeah.
It's bristly.
So, as a matter of fact,
Only there's gunk on the shikiasu.
right. And even then, so I would just assume that you don't use it, and then if ever there's a time you really need it, you know. So for testing purposes, you could even just ignore it. Ask about that. So we're gonna also clean under, but I'm not letting go, right? So I'm still holding the trach, because this is gonna make him cough probably, so I wanna make sure that I'm securing that. I'm always going from inside of the stoma out. And then if there's anything else to clean, I can use these. Usually up here. This is also a good time to clean their neck if you need to clean their neck. You know, sometimes, especially if you have a patient who sweats a lot, it can get really kind of rank under there. So make sure everything's dry. Dry it. Because I have everything here, I'm actually going to do everything at once. So I'm going to take his inner cannula out. I'm just going to throw that away. Put a new one in. All right. Make sure there are no wrinkles. I saw the other day, some people are allowing a lot of wrinkles there. Remember, wrinkles will cause breakdown.
Right.
And we're going to use a new tie, which looks strangely like the old tie for today. All right. So I'm just checking before I leave. I kind of pulled the don't think the station, does it feel hard? There's really not a lot of crazy steps on this one. Make sure you remind yourself to deflate the cuff when you need to. That's probably the most challenging thing. And not let go of the trach.
Will all be in order? I'm like inserting it.
Yeah, the only thing, I might put the cleaning in between, I can't remember. But if you know, if you've been practicing it a different way, I don't care. So if you tell me, you know, can I do it in a different order, that's fine.
Will we at the end put him back on oxygen?
If he was on oxygen, you absolutely, yeah, he wouldn't have come off it really. He would have kept this like this, kind of just sitting here. Like that, so he's just getting a little bit of blow-by. And you're watching your SpO2 in the real clinical setting. So if his SpO2 is drifting, then we probably need to get a little bit closer.
Or if he was on a nasal cannula.
He wouldn't be on a nasal cannula except for during the capping part,
Okay. I see.
right? Because right now, it's sealed, so
Okay, yeah, I understand.
So in the, for the checkoff, you want us to place first insert the trach, then do the passing mirror and then clean? Or
you can pick. If I was doing it, I might do the passing mirror and the capping together just so I don't get mixed up. Because if you kind of put cleaning in between, you might forget to deflate the cuff at some point.
Okay.
So if it was me, if I was stepping into the station, I would probably put the trach in. As a matter of fact, if you wanted to, put the trach in and then clean right away.
Oh,
That's
okay.
done. And then you could do passing mirror, cap, and then if I ask you to decannulate. So actually, I didn't show you decannulation. Does you guys remember decannulation?
Just pull it all out.
That's it. You pull it out and you put the
wet to
4x4,
dry.
yeah, wet to dry.
That's it, just pull it out.
That's really it. It's so much easier than you think it should be, right? Like, this is the big deal, or decannulating is not.
When we're decannulating, he has to be in sniffing position, no?
I decannulate most of my patients just like this, because mechanic-wise, which way is he gonna be able to breathe better? Here. Why? Saturday morning, I know it's too early for these questions. What's the
You
difference?
mentioned something about that.
The draining?
What's the difference between this and him being laying down in terms of mechanics?
Draining, right?
I think something about, somebody said something
Gravity.
about the,
Improves his ability to breathe.
Why?
I think the
That
diaphragm.
was repeating.
Yes, I think you're right. So the diaphragm. Right now, the diaphragm is kind of pushed
Pushing,
down.
yeah.
It can do its things pretty easily. If I was to flip him even flat, what happens to the abdominal contents? They push up against the diaphragm and they make it harder to breathe, even for us. So you know that if you're having trouble breathing in the middle of the night and you were laying down, first thing you do is sit up, because it's easier to breathe. So if you can decannulate him in a sitting up position, you're just kind of making it easier for him. And there's really no reason not to, because this is it. And then we're done. In order to put the dressing on, you might have to have him just put his head back a little bit, so you might pull the pillow out. But I'm really not going to be that picky for the check-off. As long as you hold on to the trach, and as long as you remember to deflate the cuff, those are kind of the ones that I'm concerned about. All right. Have fun.
Got it?
Thank you for joining me on this wonderful Saturday.